Great, thank you so much. Okay, so we're going to talk about thromboprophylaxis with a focus on the shift in aspirin. And so let's dive into that again. Here are my disclosures. The objectives, we're going to just review the burden of venous thromboembolic events, or VTE, and why it's really important in orthopedics. What is the best evidence regarding aspirin as thromboprophylaxis agents? And then we'll talk through a suggested thromboprophylaxis algorithm. So the burden of VTE, it's no surprise to people in this room, but pulmonary embolism still remains a sequelae of trauma that is still preventable. And DVT can carry with them significant dysfunction. This infographic suggests that 1 in every 6 minutes, 1 American dies of a venous thromboembolic event. This is extremely costly as well, in the US costing over $10 billion annually. How does that relate to orthopedics? Well, Virchow's triad really illustrates how orthopedic injury in particular is susceptible to increased VTE risk, such that our patients are up to 7-fold increased risk of VTE despite actually our current thromboprophylaxis regimens. And that's because of the endothelial injury that ensues from the injury, but then also our surgical procedures. Venous stasis, they're not as mobile, even if we have them mobilizing immediately postoperatively. And we know that it's well established that these patients are hypercoagulable after injury. So our options at the moment really fall into 2 major camps: anticoagulants, which really inhibit fibrin clot formation, and they target different areas of clotting factors. So for example, a low molecular weight heparin targets antithrombin. Some of our direct oral anticoagulants will target a specific factor like 10A. Antiplatelets, on the other hand, actually inhibit platelet aggregation. And aspirin, for example, is a COX-1 inhibitor, so it also has some anti-inflammatory properties as well. So this has really led to this large trial that most of you, I'm sure, are familiar with. I'm going to summarize it very briefly, the PREVENT CLOT trial, which was a pragmatic, multi-center, non-inferiority randomized controlled trial. Over 12,000 patients with extremity injuries that were treated operatively, and patients that had pelvic or acetabular injuries that were treated operatively or non-operatively. Patients were randomized to receive either enoxaparin twice daily or aspirin twice daily. If we look at the main outcome, all-cause mortality was the primary outcome, and in blue here we have the intention to treat analysis, and in red the per protocol. And both really suggest that there was no difference in all-cause mortality between those that received enoxaparin and those that received aspirin thromboprophylaxis. If we look at deep vein thrombosis, this is really important. Proximal DVT, you can see the confidence interval does cross the midline. There was no difference in proximal DVT between the 2 thromboprophylaxis regimens. However, if we do look at distal DVT, those who received aspirin were at higher risk of a distal DVT. And so this study has really concluded that aspirin is non-inferior, and that's very important, not superior. It is non-inferior to low molecular weight heparin, in this case enoxaparin, at preventing all-cause mortality, death due to pulmonary embolism, or proximal DVT. However, there was a difference noted in distal DVT, with the rate being 0.9% in those that received low molecular weight heparin and 1.5% in those that received aspirin as a thromboprophylaxis agent. So then the question really became, well, what about the severely injured patient, the higher risk patient? And so this is a secondary study and analysis of the PREVENT CLOT trial that risk stratified patients into low, medium, high, and high risk based on the Caprini score. They used a win ratio analysis where essentially they picked mortality as the most important outcome, followed by pulmonary embolism, followed by DVT, and then bleeding. And this study really reported that thromboembolic outcomes were similar between the 2 groups, and that it didn't matter sort of the risk stratification based on Caprini score for these patients. Both had similar overall event rates. When patient satisfaction is incorporated, this will be no surprise, patients prefer an oral medication over injections twice a day. So I'd like to shift gears a little bit here and show you a little bit of our translational work from my lab. So this is just under 300 patients that had hip fractures. We followed them serially over time with thrombolastography analysis. This is a very typical cohort of hip fracture patients based on age and sex breakdown. And so I'll orient you here a little bit. This is maximal amplitude, which is one of the parameters in TAG analysis that allows us to look at clot strength. This is trended over time out to 3 months for this whole cohort. And a couple of major findings we can see, not surprisingly, patients are hypercoagulable. They are at risk for VTE events. It peaks at around 2 weeks. But importantly, in hip fracture patients, over 50% of our patients remained hypercoagulable based on TIG analysis at 6 weeks. This is a new technology called platelet mapping. This actually allows us to look at how platelets are stimulated and how hyperactive they are. So this is now looking at the maximal amplitude, so clot strength, but looking only at the arachidonic acid pathway, which is targeted by aspirin. The dashed line is at 55 millimeters, and we believe this is a threshold for hyperactivity of platelets. So these are the same almost 300 patients with hip fractures, and we can see that platelets are hyperactive in these patients from about post-op day 3, certainly through 4 weeks, with some remaining having platelet hyperactivity out to about 6 weeks. So then we wanted to look at, can we measure the effect of aspirin as a thromboprophylactic agent? So I'll orient you here. The teal line is those 300 patients that had hip fractures. And then the gray line is 13 patients, so arguably a very small pilot study that we've conducted that had aspirin thromboprophylaxis. But you can clearly see here, though there's some variability and a small sample size, aspirin as a thromboprophylaxis agent does inhibit platelet hyperactivity, and it reduces it below that area, that line of hyperactivity that we seem to be quite concerned about for VTE events. And so some more work going on in this area. But lastly, I want to highlight the fact that our patients, our trauma patients, have both platelet hyperactivity that I've just shown you, but they also have hyperactivation of clotting factors. So the green line fibrinogen, if we look at that, we can see a very similar trend, how our clotting factors are overactive after injury. They peak at around 2 weeks and then slowly resolve down to normal. So if I remind us that we have antiplatelet agents that target platelet hyperactivity and anticoagulants that target our clotting factor overactivation after injury, what is the answer for thromboprophylaxis? So I'm going to suggest that we still need to look at a personalized approach. A population-based approach to say always and never is never really a good idea in orthopedics. And so this is just briefly an example of how you can do an individual risk stratification score. It's called the TRIP-CAS score. It's very easy. Risk stratification is based on the type of injury, how it's immobilized, age, sex, and a couple of very well-established risk factors for VTE. So a patient with a score of 7 or more would really benefit from some form of thromboprophylaxis. So at least keeping this in our back pocket as far as stratifying patients, I think, is really important. TRIP-CAS score works really well for outpatients that are mobile, and this is called the TEST score, Trauma Embolic Scoring System. This is better for patients that are inpatients, and it does include things like the injury severity score, which certainly can evolve over time. Similarly, though, if a patient has a score of 7 or more, thromboprophylaxis agents are recommended. So I'll walk through this very quickly. This is published in Rockwood and Green. This is now our new algorithm. We've got our low-risk patients who are over on the left, such as an isolated upper extremity or a foot fracture. If these patients do have additional risk factors based on your individual stratification, it's very reasonable to consider pharmacologic thromboprophylaxis for those patients until they're mobile. In the middle here, we have our intermediate risk patients, and a lot of our patients fall in this category. So lower extremity injuries, Achilles tendon rupture, and tibias, for example. If you do an individualized risk stratification, we really land on the fact that those that have an additional risk factor, such as surgical intervention, would definitely benefit from thromboprophylaxis. And given our best available evidence, the recommendation would be either a low molecular weight heparin or aspirin, and the duration is still something that we need to understand better, but a minimum of 14 days. In our very high-risk patients, we look at thromboprophylaxis for an extended duration with low molecular weight heparin or aspirin. So to summarize, is aspirin enough? I think our current clinical and basic science evidence suggests that ASA or aspirin is appropriate for prevention of pulmonary embolism and proximal DVT. And it's important to remember that all the evidence that we have so far is non-inferior to low molecular weight heparin, not better. Oral medications are preferred by patients, and there's a lot of work now going on oral anticoagulants and how those might be a good alternative to a low molecular weight heparin that's an injectable. Individual assessment is really important because there are contraindications to aspirin, such as allergy, prior GI ulcer, or thrombocytopenia, for example. And similarly, anticoagulants also have contraindications. So individual risk stratification and looking at their medical profile will help keep us all safe. Last slide, a world of opportunity with a lot of unanswered questions. My lab is certainly working on helping to address some of those, but lots to work on. Twice daily versus daily dosing, oral anticoagulants for thromboprophylaxis, how long should we be prophylaxing our patients, and what is the clinical significance of these distal DVTs? Thank you.